Okay, thanks very much. We're going to move now to the service specification for specialised services. Ian.
Thank you, Malcolm. Board members will understand that from the 1st of April, the National Commissioning Board, so the NHS Commissioning Board, is the sole purchaser of specialised services for people right across England, which is an immense responsibility and cuts directly, I think, to what we heard from Robert Francis earlier about our role as a commissioner in setting standards and ensuring that they're carried out appropriately for patients across the country. So that's a big responsibility that I know the board's taken really seriously. What this paper does is update us on, I think, the really quite significant work that is being done to bring about national consistency in relation to specialised services. You'll recall from the discussion we had previously that the last few years we've been on a journey through the Carter report in 2006 towards getting equivalent quality of care right across the country, but we haven't got that at the moment in every area, and it's incumbent upon us as a national commissioner to ensure that patients right across the country get access to high quality services all the time. And to achieve that, board members will understand that for the last 12 months we've had huge numbers of clinicians working in clinical reference groups to look at both eligibility criteria, but also importantly the standards that patients should expect from the NHS in these really important services. It's the first time that's been a national process of that sort in the history of the NHS, so it is significant, and over 1,200 senior clinicians and patients have been involved in that process. So it is significant. You'll recall that in December I brought to board and got permission from the board to take the service specifications and the policies out to a discussion and engagement with stakeholders. I have to say I would want at this point to thank the 3,500 individuals and organisations that responded to that. I think it's a phenomenal response and indicative of the importance of these services to patients. And so, we've had a huge response, and that's been incredibly helpful. We're working now with the support of the Medical Directorate and the Patients Insight and Informatics Directorate to work through that mass of material, and indeed to engage in a series of events with people who have taken the time to correspond with us, so we can have a proper engagement with them. That work will go on now, I think, through to the end of this financial year. So there's a lot of work being done to actually engage with people, which I think is really important. That, I think, has consequences for us in terms of the policies and specifications, and what I wanted to do is effectively update you on where we are and suggest the way forward, which at least in relation to part of it, I'm suggesting an alternative timescale to give us more time to engage with those people who've taken the time to interact with us, to make sure that we're really hearing what they had to say and understanding its context. So let me turn now to the clinical access policies, which are effectively the eligibility criteria for accessing specialised services. And board members will understand that to meet our obligations, they have to be in place from the 1st of April. And there are around 30 clinical access policies that will need to be formally adopted by the board in advance of the 1st of April. To deal with that, and picking up very much on the point about dealing with this in a way that doesn't bring huge amounts of clinical detail to groups like this, but does provide proper governance around it, I'm proposing that we agree in principle today to establish a clinical priorities advisory group, which would meet before April, but then would be constituted to meet as an ongoing part of the governance of this organisation, working closely, I think, with the devolved clinical structures that Bill has just described and some things feeding into that, which would bring together key clinicians and key patient representatives to work on behalf of the board to advise on the clinical effectiveness, the cost effectiveness, the appropriateness and the relative priority of treatments and services. So it's an important set of clinically related functions that are really important for patients. And we need a way first, I think, before April to establish this mechanism, to constitute it in such a way that it can sign off with appropriate delegation the policies we need from the 1st of April. But in a way, that's the mere first stage of this. The big work then starts after April as new treatments come along, and we need a basis for a proper, transparent, evidence-based and credible set of assessments as to how we deal with those proposals as they come up. We will be subject rightly, and we should welcome this, to very significant scrutiny in these areas. And this mechanism would, I think, help us to discharge our onerous but important responsibilities and also be completely transparent about how we do that. So that feels an important set of conversations. So I'll be asking for your support in principle to establish a CPAG before the end of the year. We're still working through some of the governance details. As you can imagine, this is moving in real time. So I'm asking for an in principle approval and delegated authority to perhaps the Chief Executive and the Chairman to sign off the details. But
So the CPAG is advisory, it's not executive.
it's advisory in that sense, but it will have to act to sign off the policies on our behalf before the 1st of April. So we'll have some formality around it in terms of its first meeting at the least. It becomes an advisory format after that, and we need to draw the terms of reference up for that.
Well, we need a proper governance
Yes, we
delegated
do.
arrangement to the 1st of April to have that in place.
Exactly.
But
So what I'm proposing is that in principle to work with Bill over the next
Yes.
couple of weeks to devise that and to get that signed off with Chairman and Chief Executive's approval. If I can move on to the specifications, you'll recall that originally these are the descriptions of the service quality that we need to be in place across England to deal with the variability we've got at the moment. You'll recall that originally when we discussed this previously, we had thought we would want these in place from the 1st of April. My recommendation to the board is that in the light of the volume of comments we've had in and the need to engage properly and really take seriously the comments we've had in and engage with the stakeholders, that we take a longer time to consider that. And that therefore we phase in the specifications when they have been properly, when we've considered the responses and taken them through the advisory structures that we will have from the 1st of October rather than from the 1st of April. I think that is a prudent move and one that is in line with the kind of good practice in engagement that we would want to deal with 3,500 responses. So in summary, I'm asking that the board sets up a process for approving the policies before the 1st of April, and that offline we develop the appropriate governance around that and get Chairman and Chief Executive sign off for that over the next couple of weeks, that we support the process of specifications but recognise that they will phase in now from the 1st of October using derogation as we've discussed before if necessary. And then the third thing is to establish the clinical policies advisory group. So I think that's what I'm asking the board's support for this afternoon.
okay, thank you. Bruce, you're nodding.
Yes,
Yes.
present this produced jointly between Ian's directorate and the clinical directorates, and we're
Thank
very
you.
supportive.
Are we happy to endorse those 3 proposals? Hesitation, Victor?
Well, I just don't know whether this is the right place to say this, and we often, listening to the presentations, there's an awful lot of process procedure, which is fine, but I just wondered whether we had, and I can't remember whether we have or not, actually looked at the interface between these specialist commissioning services and things like our duty to ensure parity of esteem between mental and physical health. So let me give you an example. In London, where I'm currently doing some work on the police response to mental health incidents, what's apparent is that there is a gap which directly affects people who have crisis mental health incidents in terms of the provision of specialist services, possibly at Section 136 suites and what have you. Now, I'm not expecting a response, but I guess what I'm concerned about is the link between those specialist services, which may be feeding points from non-specialist services, And mental health is one of those areas where, in my view, we have to make significant improvements in order to get paritative esteem in specialist, in order to get paritative esteem between physical and mental health in specialist services, and they're linked to non-specialist services. Do you understand? And it seems to me that's a significant test of our ability to commission specialist services. If we can, if one of the key interventions that will move the needle towards paritative esteem mental health will be, I think, our commissioning of the right designed specialist services and linking it to the non-specialist services, where there is currently, in my view, a gap, a significant gap. I don't know whether or how we're going to deal with that issue or issues like it.
Perhaps I'll make some immediate comments. And
Unless Kieran wanted to come in on the same point.
Sorry, fine.
Yes, please then respond to
Let
this.
me kick it off, and then I'm sure Bruce may wish to comment as well. I think the point is well made, really. We're trying to ensure, I think, two different things through this process of commissioning specialist services. The first is that patients across the country get access to high quality care, and that we discharge our own responsibilities as a commissioner of that care, as outlined by Robert Francis earlier, and that's what the discussion, I think, as part of the transition now is about. But I think absolutely, if you think back to the discussions we had around everyone counts, we were very clear that this is also about pathways of care. And so, whether you look at patients with cancer or patients with mental health problems, they may well move through the full spectrum of care, from primary care through to secondary care, through to specialist services, and then doubtless we'll go back to primary care. And so I think one of the things we do need to do, absolutely, as a commissioner, working through the local teams that are driving this at the local level, is look how these services join together and how pathways work. So I think you raise an important point. I don't think that's likely to be, in inverted commas, something that's cracked through the mechanisms necessarily in themselves we've got now. I think that is absolutely about the exercise of commissioning responsibility through the area teams that are driving that, and indeed engaging in local conversations through health and wellbeing boards and with CCGs. That's, I think, where that pathway discussion happens. I don't know, Bruce, whether you want to add to that from a clinical perspective.
I don't think I have much to add other than to say I think it's a really, really important topic. So we will be bringing to the executive team a paper which is almost completed on our strategy for mental health, which has been written by Martin McShane, the Director of Long-Term Conditions. What we will do, though, is make sure that set of proposals links in closely with mental health and the associated specialised services, because I think you raise a very good point of connectivity. Thank you.
Yes, Barbara. On this point.
Yes,
Yes.
just on this point, just to say that we've got some work going on, in our role in kind of developing the commissioning system as a whole, between some CCG leaders and the regions and the area teams in the operations directorate, looking at how can we make the commissioning joined up so that the provision is joined up, which is the key thing. But it's in its infancy, but it is something people are very aware of, and we've started.
Thank you. Kieran.
It's been a huge amount of work, and I think the fact we've got as far as we have is credit to everybody who did that. There was a feeling through it that it was very clinical, and there are a number of people, a number of organisations who went into writing saying, look, we're being kept out of this. It would be good at moving forward if we maybe erred on the side of participation. I know I think suggesting extending the time is a perfect response to that, particularly given the volume of responses. But it works on the specification side, but I think it also works on the clinical priority side. I think err on the side of demonstrating the culture we're moving into in the design of that group as well.
So I have to respond to that, other than say I think one of the reasons that we want to give proper time to what we have to do now is to have the kind of engagement that I think we need absolutely going forward. The patient needs to be at the centre of this process, and our mechanisms need to absolutely ensure that that's the case. So I think there is real commitment to doing that from the team that's driving this forward. Yeah, but everything you said seems exactly right.
And I accept the rush.
Right. Ian, thank you.
Thank you, Chairman.
Very much indeed. We move on now to a paper on CCG authorisation. Victor, do you want to introduce this?
We should never start a report by saying sorry, but sorry, there's an error in the board paper on the authorisation, which basically says that Bromley CCG is collaborating with Ealing and Harrow CCG. It should say Brent. Brent, not Bromley. I'm told the website is has been corrected, so that you know. Naguib has made the point that I wish to make, and I'm sure that Kieran would join me in being very impressed actually with the work that's been done by the administrative support and Barbara's team on getting just a huge amount of information, data sorted out into reasonable and rational chunks for us to deal with. I would also make the point, or repeat the point, that the authorisation process is the best that we can be given, best that we can have given the time and resources available to us, and we are going at a hell of a pace. That said, the paper speaks for itself. There's another meeting on the 22nd, I think it is, of March. We'll be doing Wave 4. I think it is Wave 4, isn't it? I think Wave 4.
I think the 22nd's roundup.
Roundup.
We've got
We've got another one before then, haven't we?
Wave 4.
See, it just goes to show that as the waves have come in, we've learned to surf them. And Wave 4 will be a roundup. I'm looking forward to the development stage, actually, because that's key. I know that we've raised issues about the appointment of chief nurses, and that's something of concern to us all as we push forward. But I think it's an impressive process given what we've had to deal with by way of resource.
It truly has been an extraordinary process. I mean, we only have to do it once, but that means we only have one chance to get it right. So I think we're immensely grateful, Barbara, to you and your team for having steered this so superbly through what could have been a very difficult process. And Victor, thank you for chairing the committee. Are there comments on the report that we've had? I think simply to commend this. And the great sense of optimism I felt last night when people were talking about CCGs, and one of those whom we met said, you know, it's not right to talk about CCGs as somehow immature organisations coming onto the scene. These are organisations that are already active, are working closely and collaboratively, and are already, at their best anyway, demonstrating the very strengths that we hold out for them. Barbara has been consistent in telling us that we need to strive for being the very best CCG you possibly could be, and I'm optimistic that we will see many falling into that category at the outset and others following them into it as experience develops.
Can I just, sorry, Chair, I just wanted to add that given the Francis comments, I think that the board members, I've visited a number of CCGs, and the thing that they're going to have to be really good at doing is being very visible in their communities and developing this community connection with commissioning. My apologies for...
No, thank you very much. We have a report from the CSU committee. Myra?
Thanks, Malcolm. I'll be brief. We've had two meetings. The second one was on Monday, and apologies that you haven't yet got minutes, but the acting on behalf of the board, obviously, to assure this hosting process and be helpful to CSUs is, you know, it's a challenge, but we agreed a balanced scorecard of underpinning indicators that will help us in that process, and supported the development programme that colleagues had developed to help the quality of service that CSUs were providing be as good as it can possibly be. But we did have in our second meeting a very significant discussion, really, that actually we think belongs better in the board, and with the help of a developed paper from that, would like to bring it back to a development session, because it's about CSUs are obviously part of that, the board's approach to commissioning support, as it were. We also think that actually it would be really helpful, and we know that colleagues are extremely busy, but for board members to engage with CSUs, and we'll be offering that. The CSUs are going to offer to make that as easy as possible for people to do, which will help enrich that discussion. And of course, again, we talked about the market strategy, which again is really board business and will be coming back. And ideally, we'll be able to deal with some of that, at least in the board development session. But encouragingly, we did get very good external assurance about the operational management and short-term viability of the CSUs from our RSM tenant, which was encouraging. Less encouraging was the fact that the plans for delegation to CSUs had not come to fruition, and that's still a struggle that, again, that colleagues are continuing to work through. But on the whole, big issues to be dealt with, but again, people are working very hard to make sense of things. But I think it would be good, again, if people can take up those opportunities, or at least some people can take up those opportunities to engage with the CSUs to enrich that conversation.
Thank you very much, Moira. Right, I think we received the report. We look forward to a developed paper and to further discussion in the future. Audit, Ed.
Thank you. Malcolm, and the Audit Committee meets obviously to focus particularly on, at this stage, readiness and the finance function readiness, but also the overall critical success factors, and also to look forward to the governance and structures for 13-14. I thought it would be helpful just to briefly update the board on where we are with respect to the finance function transition. Clearly an enormous amount of work is being done. We asked Deloitte before Christmas to come in and review the 13 work streams which Paul is working on, and I reported last month on their first pass. 2 weeks ago they gave us a second pass on where they thought we were in terms of readiness, and I'll just briefly highlight some of the issues that they have raised with us, which Paul had already raised with me, and which are known obviously to the Department of Health. Clearly the whole build-up of the finance function was slower than we had hoped because of the requirements to go through due process and things. So we brought in, Paul brought in additional resources that are within our authorisation from Deloitte to help have people on the ground to progress some of the activities. That's made good progress in a number of areas, but there are some risks, and the risks are around, firstly, the operation of the financial spine, which is a brand new system with a brand new charter of accounts for a brand new organisation, and the whole mechanism of bringing that in doesn't give us the opportunity to parallel run or even to trial run the trial balance. We have Ernst & Young coming in to give us an assurance on the way in which that will go in, but there is inevitably a risk with that, although we're hopeful that, we're certainly more than hopeful that the technology certainly works. The issue, I think, is the operation of that system on the ground by hundreds of people. So there's a very substantial training process going on with train the trainers, and it's really important that the system out there releases people to go through the training so that they can operate the system. The second one is one which Bill has already talked about, and I'll just mention briefly, is this whole take-on of people and the records around people coming on board and paying people from the 1st of April. A huge amount of effort is now going into that, and we will keep that pretty closely monitored. Third area, which is more for 13-14 but quite important in the early stage of 13-14, is the whole design of the management reporting framework to give us the board information and management, the management information they need. And that's running a bit behind schedule, but new resources being brought in to help that process. Fourthly, direct commissioning and the way in which direct commissioning interacts with the finance function, and making sure we know what we're spending and how we're spending it through the course of 13-14. And then a couple of other issues, one which we have raised with DH on the NHS Property Services and the way in which that will operate in future years, certainly with respect to us only paying for property costs that properties we actually occupy, as opposed to any surplus property that exists in the system. So we're monitoring all of those. We have Deloitte, at Paul's instigation, doing a further review this week and next week, and then coming together with us, particularly focusing on day one, month one priorities for operation, and then month 2 and month 3. So moving away from an overall work stream approach to an activity-based, what do we need to operate? And we will report through Paul to the exec and through me to the board on the progress with that third review. We also looked at Bill's overall readiness, and one point that did come out of that, which we think it's important to say to the board, is we want as clean a balance sheet for the Commissioning Board as we can possibly have from the 1st of April. And there is a whole load of transfer of assets and liabilities from the prior system into the new system. And we think there is an enormous amount of work to do. There are some risks in that. And our strong advice is that we have to enter into dialogue with the Department of Health on them acting essentially as close to a residuary body as possible. And that is a really important thing, and I know Margaret feels quite strongly about that with respect to inherited liabilities. So on Monday, when we have a board-to-board meeting with the department, I hope that we can raise that and have further dialogue with them. I've mentioned the delight that we have with the Clinical Risk and Quality Committee. Most of the other things are about the forward projection, but all important. The recruitment of internal audit is in process. The external audit is being appointed to the CCGs by the Audit Commission is in process. Identification of risks for the operation of the system rather than transition is in progress, and the whole board assurance framework. And I think I would just say finally that the spirit of doing this is completely open and transparent with both the Department of Health, completely transparent with the Audit Committee in sharing what is going on, and with the National Audit Office, who are engaged with us at every stage and obviously have their views and are providing our advice. So that's a sort of verbal report which I know comes at the end of a long meeting and is perhaps of less import than some of the critical things we've covered. But I do want to make the board aware of the fact that we are going through a bumpy transition, and there will be bumps in the road in the early stages. I don't know, Paul, if you want to add anything to that.
No, yeah, very much accords with the view that I would have, and I appreciate the support of the Audit Committee in making it work.
Yes, I think we also appreciate the support of the Audit Committee and your skill and that of your colleagues in pinning down each of these issues and analysing them so closely. We, all of us, need that reassurance. As you say, it's very bumpy. There's stuff being done here that's never been done before, and it's very nervous-making. So we're grateful to you for the assurance that you're able to give us. Are there any issues anybody would wish to raise with Ed?
I'm just struck by a comment that he's made in his written comment on the paper. And he says, if you step back and read the paper, the focus of the paper is on process and systems. There's no real consideration of how this cutover may affect patients and what risks exists in terms of the patient experience. And I'm struck by it because we talk about it as though it's separate from patient experience. And I just wonder whether there is a link or whether that's a fear imagined. You see what I mean?
Well, I think there is a link very clearly in the sense that everything we're building, however tedious or boring some of it may sound, has got a single purpose, which is to improve outcomes for patients by putting them at the centre of all we do. And we will, through the kind of work that Tim's been talking about, we will be tracking the impact that our new organisation, the way we've built it, can have on patient outcomes. There are some very direct ones. Ian's talked about the importance of specialised commissioning and the continued handover there. Barbara talks all the time about CCGs taking on their responsibilities in an effective way which faces patients and gives them the best quality of care. So I do understand the Gibbs point, but I actually think it's the thread which holds together everything we're doing.
Cool.
I think it's highly appropriate that we started the day with the patient experience, and we've come right round back to it, and I think that's hugely symbolic of the role of the board. I have no other business except to remind you that the next meeting of the board is on the 12th of April in London, and that will be the first meeting of the board with its full array of statutory powers. May I thank everybody for attending the meeting today, thank members of the public who have joined us, and I declare the meeting closed. Thank you.